Now, please, I call Professor Sameh elimam from Al-Azhar. He's going to talk about outcomes of venoplasty with a stent deployment for chronic iliofemoral thrombosis.
Dear Chairman, dear colleagues, my talk, we will talk about the outcomes of venoplasty with a stent deployment for chronic iliofemoral thrombosis. We will found the blood clots, one or more, in the iliofemoral segment. This is what we call the iliofemoral thrombosis. Virchow in 1956 has mentioned his triad about the damage of endothelium in the vein, the venostasis, and increased viscosity, adding the hypercoagulability of the blood. This is the pathogenesis. It didn't differ from that time. The clinical manifestation of DVT, it varies from classical picture, asymptomatic picture, and complication group. The classical pictures, it varies from pain, swelling, tenderness. The complication group, the asymptomatic group, especially in the cancer patient and pregnant woman. The investigations of iliofemoral thrombosis, we're going to classify two non-invasive investigations and invasive ones. The non-invasive, of course, it's going to be the duplex ultrasound. The invasive is going to be the venography or invasive ultrasound or intravascular ultrasound. The lines of treatment, it differs from general measures, pharmacologic therapy, venous thrombectomy, thrombolytic therapy, open surgical reconstruction, which replaced by balloon angioplasty and stenting, which will the work we will offer now. Our aim was to highlight the outcomes of venous dilatation with the stenting for chronic iliofemoral thrombosis. This study was conducted in Al Zahra University Hospital from 2013 to 2015 on 20 patients who included the patients above 20 years old and less than 60 years old, confirmed with yoni or bi-iliofemoral DVT. We excluded the patient with ejection fraction less than 20%, which already have exposure previously to radiation, also with acute thrombosis. Our methods, we didn't found any big differences between the ordinary methods. It was local anesthesia in the groin. Most of them, about 16 patients, 4 patients only in the popliteal vein. We needed to puncture the popliteal vein. The wires is 0.35 standard wire, and sometimes we needed the stiff wire. The sheaths, we used 6 French sheaths in 10 patients, 12 in 14 patients, and 9 French sheaths in 2 patients. We used a clear back balloon, an Atlas balloon. The low pressure balloon, we used it in 12 patients. The high pressure Atlas, we used it in 8 patients. The stents we used Venovo, Illuminax, and wall stents. This picture show the venous pre-op and post-op. We have see here an occlusion in the right iliofemoral segment. Then I don't have pointer, I'm sorry, but we can see the balloon. After the balloon, we see the dilatation. After that, we stenting, then post-stent deployment venography. We have a completely open segment of iliofemoral segment. We found a very good results in comparing to the guidelines. The pain had decreased. At the first, the pain was already presented with 45%. Post-operative, the pain represented with only 10%. The swelling also have been decreased. By the way, all patients were presented with the swelling of the limb. About from 100% to 35%, we had decreased the swelling of the lower limb. The pigmentation, it didn't improve much better. But actually, we didn't search for improvement of the pigmentation. It was just a symptom, and we found a relief in the symptom. As regard the ulceration, which was more important as regards C5 and C6 and C classification, we found a partial healing in about 30% of patients and complete healing in only 25% of patients, as it showed here in the Kaplan-Meier curve. The complete healing was found only in 5 patients. Post-operative partial healing was found in only 2 patients. Our technical success was 100%. The patency discharge rate for the stent, after 1 day of the operation, it was 100%. After 1 year follow-up, of course with duplex ultrasound, the patency rate of the graft showing a decrease, it showed a decrease in its rate. Also, it dropped from 100% to 80% after 12 months. I think it's a very good percent as regarding the global patency rate. Finally, we concluded that the balloon dilatation alone was insufficient in the venous system. Most iliofemoral chronic occlusion lesions could be successfully recanalized percutaneously with very little morbidity, minimal downtime, sustained long-term stem patency, and substantial clinical improvement. Thank you.